run the slides and pull up all the stuff. And so all you got to do is just talk. Yeah. And if you say, just say next slide or whatever it is. Okay. And I will be facilitating. So I'm going to do the intro. And then I'll let you know when to jump in. Okay. Okay. Let's see. Can we start? Oh, it's 2 o'clock. So, John, can you let everybody in?
Okay.
Welcome, everybody. Thanks for joining us again. This is Dr. Aida Wen, a geriatrician with Department of Geriatric Medicine at JAPSOM. Thank you for joining us for this series, the Long-Term Services and Supports COVID Preparation Series. Next slide. Just want to say special thanks to our other collaborators, which is the Hawaii Emergency Management Agency, HAH, Hawaii Association Director of Nursing, HAMDA, Mountain Pacific Quality Health, and of course, DOH is working very, very closely with us. Next slide, just want to show that we have a calendar going on, and actually if you want to see the full calendar, just go onto our ECHO website and you can see the most updated one. Sometimes it changes a little bit. So, okay, so today's webinar will be about 30 minutes in length. After a short lecture, we will open the floor to discussions. Please use the chat box at this time to submit any questions you may have. Also, questions that we don't get to, we may include answers on the website or later on in future webinars. And we ask you at this time to enter the names of all attendees in the chat, all you guys into the chat box for attendance purposes. We apologize for the inconvenience, but we will not be offering CMEs for the activity due to time constraints. We can offer certificates of attendance to all participants who complete an online evaluation, and evaluations can be found on our website under the evaluations tab and following a link in the chat box. This and all our other COVID series is recorded and can be accessed at any point, and there is actually a tab for downloaded resources as well, which you can always go back to, and we will be updating those as we go along. So today we are going to be talking about proper COVID testing. We will cover the nasopharyngeal swab. Oh no, okay, hold on. Okay, the nasopharyngeal swab and decision management. And today's speakers are Caitlin Cook, who is an MPH and antimicrobial resistance epidemiologist at the Department of Health, and Sarah Kemble, who is the Deputy State Epidemiologist at the Department of Health. And so at this point, I'm just going to open the floor to our speakers. Thank you very much.
Hi, this is Caitlin. I think we were going to start with a video of the swab collection, right?
John, can you pull up the video?
Do you see it now? Hello?
Yes. I
Yes.
do see it. It looks like we just need to play, yeah.
Okay, I will play it now.
John, is there sound?
Hello, is the sound coming out?
No, there's no sound.
Okay, let me try that again.
With a plastic flexible shaft, viral transport media, facial tissues, a flashlight, alcohol-based hand rub, EPA-approved disinfectant wipes known to kill human coronavirus, a waste container lined with a waste bag, laboratory transport biohazard bags, patient identification labels, a permanent ink ballpoint pen in dark blue or black ink, and absorbent pads. As healthcare workers prepare to collect a nasopharyngeal swab, they should be mindful that the patient may be experiencing anxiety and fear. It will be important for the healthcare worker to provide an explanation of the procedure and reassurance as needed. If there is concern that the patient may react negatively by reaching for the swab or pushing the provider away, for instance, consider having a buddy standing by to assist if necessary. If the patient is a pediatric, distraction techniques may be required. As with any procedure, ensure institutional protocols are followed at all times. To begin, follow your facility protocol for identifying the correct patient and preparing the procedure area. Raise the head of the bed to a comfortable height for the procedure. Ensure the patient is in a comfortable position to help facilitate the specimen collection. Prepare equipment by placing items on a disinfected bedside table. Prepare the items on the table in a manner that is conducive to performing the procedure. Place packaging into the waste container unless it is required to maintain sterility of the equipment. Unscrew the cap from the vial containing the transport medium, but leave the cap on top of the vial. Place an opened disinfectant wipe on the clean table in preparation to receive the container after sample collection. Once you are ready to obtain the specimen, perform hand hygiene. Healthcare workers must be mindful of the potential contamination risks they may encounter during the specimen collection, including exposure to infected bodily fluids and the potential contamination of personal protective equipment. Barriers can be used during the procedure to help mitigate this risk. For instance, strategically placed absorbent pads can protect bed linens from exposure to body fluids that may be expelled during the procedure. Drape an absorbent pad over the patient's chest to collect any spills or respiratory droplets. Ask the patient to blow their nose with a tissue to clear their nostrils. Using a flashlight, inspect inside the patient's nostrils to ensure there are no obstructions, such as a deviated septum. Pick up the nasopharyngeal swab, holding it between your thumb and forefinger with the shaft resting on your middle finger. Have the patient tilt their head back. A pillow placed beneath the patient's shoulders can help facilitate the tilting of their head. Place your other hand firmly yet gently on the patient's forehead to help keep their head in the desired position for the procedure. Throughout the procedure, be mindful of your body positioning. In the event of a patient sneeze, you will want to ensure you are standing to the side of the patient, out of the direct path of respiratory droplets. Insert the swab into the patient's nostril parallel to the palate. It is helpful to have the patient clench their eyes shut as the swab is inserted, as this can help inhibit the sneeze reflex. It is also helpful to turn the swab gently as the swab is advanced. Once you feel resistance and the swab has been inserted at the expected depth, leave the swab in place for a few seconds to absorb secretions. Gently withdraw the nasopharyngeal swab and remove your hand from the patient's forehead. Place the swab in the vial. Once the swab is inserted into the vial, break the shaft at the scored breakpoint line. Use the vial's cap as a barrier between the healthcare worker's finger and the shaft by positioning the cap over the vial while breaking the swab. Alternatively, hold a sterile gauze over the top of the vial while breaking the swab. Replace the cap and tighten to secure the vial. The remainder of the shaft that does not get packaged should be considered a sharp and placed in a sharps container. Perform hand hygiene. Wipe the nasopharyngeal specimen vial with an EPA-approved disinfectant wipe. Follow your facility policy for labeling. And place it in a laboratory transport biohazard bag. Wipe the bag with an EPA-approved disinfectant wipe and follow your facility protocols for transportation. Clean the procedural area and provide care to the patient as needed. Additional resources are available at the NETEC and CDC websites. If you have any questions, please contact NETEC directly at info@netec.org.
Okay, this is Caitlin again. I think I'll pause for questions about swab collection. I'm not a clinician, so I won't be able to answer, but Dr. Kemple might be able, if anyone has questions about the material just shown in the video.
I do have one comment I just wanted to say and follow up to the video. It wasn't shown specifically in this video, but to increase the sensitivity of your nasopharyngeal swab collection, you can do both nares with the same swab. So you can do one nare 10 seconds and then go into the other nare for another 10 seconds.
Great, thank you. Any other questions about actual collection of the swab?
There's a question, what about doing oropharyngeal with the same specimen? That has also been something that some clinicians have suggested and would also probably increase your sensitivity. I know some people are uncomfortable with doing nares to oropharyngeal. I guess you could do throat first and then nose. That's an optional step, but I think doing both nares it will probably, the additional yield for oropharyngeal may be small unless your patient is specifically complaining of sore throat. There's no specific data behind that, but I think just on clinical intuition, that might make sense.
Thank you. Maybe we can move to the next slide, please. Okay, here it looks a little busy at first, but this is a great and I think will be really useful kind of decision-making tree that Dr. Wen developed with a lot of our input and guidance, and we've had a few drafts of this. And so this is pretty current as to how the workflow is working now. I'll walk through it briefly and touch on highlight a few key points that we want to make sure don't get missed, and then we'll be available for questions about this workflow too. So on the far left, upper left corner, the first step is making sure that the patient or resident meets the screening criteria for COVID-19. So the rest of this flowchart is operating under the assumption that the patient or resident does have the symptom criteria to be screened for COVID-19. The next step is to make a decision if the resident moves to a hospital or stays in place at the facility. You know, the transfer to the hospital should really be based on what Dr. Wen has outlined here, goals of care and also the level of care required for the patient or the resident. If they're going to stay in your or if they're going to be transferred, please make sure you give the patient transport team a heads up about the suspect COVID status, and also the receiving facility a heads up about the suspect COVID status. If you're going to maintain the patient or resident in your facility, please immediately place them on isolation under contact and droplet precautions. In determining kind of how to test and where the test is going to be run in terms of which lab, DOH really does consider specimens from these congregate living and long-term care facilities a high priority for testing at the Department of Health state lab. So tests run there can have a quick turnaround time, and we'd be happy to facilitate that. However, a prerequisite for the specimen being tested at the state lab is the filling out of the PUI form and having a conversation with one of the epidemiologists at the Department of Health to ensure we can communicate with our laboratory partners to expect these specimens from this facility and to run them and test them at state lab. So the approval by the epidemiology department is really a critical piece. And don't forget that there are other options these days. DLS or CLH can also test swabs, and often they have a quite quick turnaround as well. So state lab is not the only option, but at the Department of Health, we do recognize that these are priority specimens to be tested at the Department of Health. Okay. And then while you're awaiting the result, maintain the patient or the resident in the isolation precautions as outlined above. And then once the result comes, let's start with if it's negative. So if it's negative, you know, one negative test, we never want to do any of our follow-up actions based on just the one negative test alone. We ask you to please consider the full kind of clinical and epidemiological picture when determining to discontinue, if or when to discontinue any isolation-based precautions. If someone met the criteria to be swabbed for COVID-19, they would have met the symptomatic criteria, and so they might have something else going on, such as flu, that you don't necessarily want to automatically lift your transmission-based precautions from one negative test for COVID. Positive tests we want to hear about right away at the Department of Health, so please report that to us. You can call our disease reporting line, and I see the numbers listed up in the upper right corner where it says facility calls DOH 586-4586. That's our disease reporting line, and that's a great way to reach us. And also faxing, I forgot to mention the fax numbers listed there too, 586-4595. This will kind of ignite a response from us at the Department of Health. Me and Dr. Kemble and other folks on our team will help you with the management and the response. These are pretty labor-intensive investigations. We're all aware of the high-risk setting that long-term care facilities are for spread among residents and staff members. So we are doing an aggressive response for every single, even one single confirmed positive from a long-term care facility. So you can expect a call from us, and we'll strategize with you on ideas for cohorting, contact tracing, and further testing. Contact tracing involves looking back on who, if it's a staff member or a resident, who they would have interacted with recently. And sometimes we'll even look as far back as 14 days to try to determine where the case may have been exposed. And anyone that had close contact with the case before and after their positive test. And that will determine our follow-up actions. So we'll really rely on a partnership with our contacts in the facility to give us this information that we need so that we can work together on the best follow-up actions. Well, obviously, if it's a positive confirmed lab result, continue the isolation-based precautions. I think the next box is referring to if any healthcare workers were interacting with a patient or the resident, we'll help you with a risk assessment of the healthcare workers based on the nature and the duration of the exposure, as well as what PPE the healthcare worker was wearing throughout the interaction. We can help you with that, but generally, if they're considered low risk, they may continue to work for 14 days as long as they keep a very close eye on their health and any development of symptoms. If they're medium or high risk of exposure, then we will ask them to be excluded from working at the facility for 14 days from the date of exposure. And I want to make a note about that. There's a lot of interest in getting tested right away if someone knows they were exposed. And we understand the curiosity, and we just want to make it clear that the 14-day incubation period is the 14-day incubation period, and that cannot be shortened by any number of negative tests. We really need folks to wait out the full 14 days before returning to work. The final box on the bottom left is our guidance on discontinuation of transmission-based precautions in the healthcare facility. And right now we have listed a symptoms-based resolution, so 72 hours after resolution of fever, or 7 days after onset of illness. And we're saying whichever is longer, the 72 hours or 7 days after illness onset. So I guess you could say and or whatever is longer. There's a lot there. I think I will pause, and Dr. Kemble and I can answer any questions that came up as we went through that.
Okay, in the chat box, Nicole, if a patient is tested because of a medium high risk exposure to a positive healthcare worker and the first test is negative, when do we repeat the COVID test while they are on the 14-day isolation period?
Sure. So right now we don't have a recommendation for a retest. You know, the 14-day, it's really, I think it might be helpful to think about it as an incubation period. So we know from the time someone is exposed, it could take between 2 to 14 days before they develop disease. So if someone gets tested on day 3, for example, after their exposure, that doesn't mean they won't later go on to develop disease all the way up until day 14. So, you know, people are curious, they want to get tested. So, you know, that's fine. We're not trying to stop them. That's fine. But negative tests can be reassuring, I suppose, but it doesn't really change the action, which means the healthcare worker does need to stay out for the full 14-day incubation period and make sure that they don't develop illness. If they get tested and they're positive, then it's a different story. They're considered a case themselves and we'll go a different route. Was that Sarah trying to join?
Yeah, I was just going to chime in that I would actually say we have seen some harm done by testing asymptomatic exposed healthcare workers in that it causes some confusion, I think, among staff that they think because they tested negative, and even for some of the supervisors, we've seen it cause confusion in some other situations where people got tested negative, went back to work before the 14 days, and then developed disease. So I really think this message is so important that testing is a great tool when we use it for a situation that guides us what to do. But if we use it in a situation just to answer, am I negative today, it's not actually changing the way we are going to manage healthcare worker exclusions in the facility. And that's so important to remember.
This is Dan at Hawaii Learning Groups. Could you say something about how good the test is, the sensitivity and specificity? Those PCR tests, if they're a negative test, that's supposed to be pretty good for being negative for at least the specimen collection. And
sure.
like
the specificity of a PCR test is supposed to be 99% or above. So when you have a positive, you can be pretty confident you have a positive. Now, are there ways to get false positives? Yes, through lab error, contamination of the specimen. So there are ways, and even potentially through environmental contamination. But a positive test is fairly reliable. For the PCR, the reverse transcriptase real-time PCR, but some of the other tests that are coming on the market now, we're actually seeing some more frequent false positives. So be careful about the test that your facility is using, is it one of the FDA approved tests? So that's important. And even some of the FDA approved ones have slightly different test characteristics than the RT-PCR. So that's important to be aware of. In terms of sensitivity, we're looking at, with a single nares swab, at least 90% sensitivity or above. That's still leaving some leeway for a false negative test. And that's part of why we started this presentation with a video of how to take a good nasopharyngeal swab, because it starts with specimen collection and also making sure you seal the tube properly, because sometimes if the specimen leaks, there's not enough viral transport media, and that may affect the reliability of the test. Also, the conditions under which it's transported. So if it got left out at room temperature during transport for a time, that can impact the test. There's many reasons why a negative test might not be all that.
Sorry, this is Nicole. I want to return to that retesting question if I can, because I was specifically speaking of a long-term care patient in a facility who had a medium to high-risk exposure to a positive healthcare worker. That patient, if the patient turns positive, it does change our management in the facility. So is there a recommendation interval for a retest while they were on their 14-day isolation? And at the end of the 14-day isolation, are we assured that we can take them off the isolation if they haven't had another test?
Katie,
Thanks.
do you want to take that one?
Sure. So I apologize for misunderstanding the original question. So for a patient in a long-term care setting who has had a medium or high-risk exposure to a healthcare worker, and I might just start by saying we're advocating right now for universal masking in our healthcare facilities during all patient healthcare worker interactions. So I hope everyone's doing that in our attempt to reduce the likelihood of a medium or high-risk exposure happening. You know, what we've been doing so far, if they have this exposure to a positive healthcare worker, they're considered a close contact to a known case. And what we do in the community is we place the close contacts on quarantine for 14 days since their exposure. Similar thing in the healthcare facility, we'll place them on appropriate isolation-based precautions for the full 14-day incubation period. So it's a similar concept. I actually don't think we have any recommendations to just kind of automatically test these people. I think what we would do would be recommend the isolation for the full 14 days. So they should maintain that and be strict about that. And then watch very carefully. And if anyone goes on to develop symptoms, then we would certainly recommend testing. Dr. Kemble, do you agree with that? Do you have anything to add?
I do, and I think the rationale there, we all have to remember the test is there to help us make decisions about sort of the scope of the impact of that exposure. And there are times when we may recommend more broadly testing a group of people based on the epidemiology, but the most important thing that's going to stop any outbreak in its tracks or even stop an outbreak from occurring is to get all the right infection control measures in place. And the test doesn't really change that. So as soon as we have a confirmed case in a facility, and then you're looking at exposures, it's really about implementing the correct infection control procedures right away. The testing sometimes takes a little time to see what the results are. And as we said, any individual test might be a bit unreliable. But if you got all the contact precautions in place, the masking, the transmission-based precautions, then you're taking care of the outbreak up front. And that's the really important part to remember before you even think about what the testing is going to change.
So I'm sorry to take up too much time, but I just want you all to be aware that in long-term care, our guidance is from CMS, if we have evidence of COVID spread in a nursing home, the entire nursing home needs to be on full PPE precautions. Every patient in that, every encounter, every patient needs to be treated with full PPE and precautions, including an N95. So identifying a positive COVID test in a nursing home that spread within the nursing home is very significant and does change the management significantly.
Yes, completely agreed. And that is kind of my point. So I think the question was about testing around exposures to the patient. But my point is, once you have a positive patient in your nursing home, you're going to be doing a lot of infection control changes right away. And so the testing is something we'll work out on a case-by-case basis around what other testing now is going to help you make other decisions. But the key first action is really about making sure all those measures are in place with the correct PPE.
We're at 2:30 now, but I want to show everyone the next few slides. If we could advance to the next slide, please. Okay, this is, I won't go into this, but this would be prior to the first box in the upper left-hand corner, criteria for screening for COVID-19. So I think maybe next slide, please. We really want to highlight any positive results. We really need to know about them for our follow-up actions. A single positive case, please notify us of any single case. Next slide, please. These are tables from the CDC that will guide our risk classification table for healthcare workers that were potentially exposed to COVID-19. I don't think we'll go through all of them now, but you can tell a lot of it is based on PPE use, what PPE the healthcare worker was wearing. So next slide, please. I think these are footnotes for the previous table. So I think these slides will be available to everyone else so you can read through on your own time. I want to make sure we get our eyes on all the slides here. So next slide, please. And I just want to make everyone aware of this healthcare facility transfer guidance that we've posted on our Hawaii Department of Health website that I hope might start to answer some questions that we've been getting from long-term care facilities about which patients long-term care facilities should accept and which patients long-term care facilities shouldn't accept. And excuse me, the link to this resource is at the bottom of the slide here. And you can find it by going on the Hawaii Department of Health website, the COVID-19 page. There's a little link that says resources for clinicians, and you can find it under there. So I want to be respectful of everybody's time. It's 2:32. I don't know if Dr. Campbell is able to stand for a few more minutes for questions. I think I could. There's something in the chat box. I see a few questions in the chat box. I'm just trying to read.
Okay, so sorry, this is Dr. Wen again. So I know that there's going to be a ton of questions. So before we get to the questions, I just want to just bring up a couple of points. Next slide, John. So that was the flow diagram for nursing facilities. We're actually creating one for assisted living facilities and creating another one for care home and foster homes. And so I just wanted you to be aware of that. And we will be talking about, we're not ignoring you, but that will occur later on. And then next slide. And sort of just to make you aware of current resource, I wanted to highlight the Queen's COVID hotline, which is available for some of our homebound patients. And so actually, I just want to invite really briefly, Dr. Bott, can you just talk a little bit about your service?
Yeah, so thanks for giving me a little bit of time, but basically we have a hotline available for anybody or any patient that is interested in or has questions on COVID, and we can try to delegate these patients to a certain area, whether it's the emergency department or urgent care, in the attempt to try to limit our patients from getting the surge to the emergency departments. as well as just to increase access. So just another piece out for the community.
Okay, thank you. Yeah, so, and of course, this Queens hotline is also available for folks on the neighbor islands as well for a couple of, I think, the Queens locations. But other mechanisms are actually being built right now as well. Okay, so what I'd like to do is just sort of just move on to maybe some of the Q&A, which we have in the chat box over there. And then I think, Michaela, I think you have a brief Zoom survey as well. I'm kind of wondering if you want to, I know because we're already at 2:30, if you want to do the brief Zoom survey, and then we'll just go back to the Q&A until people want to get off the line. You want to do that, Michaela?
Yeah, we're just going to ask you to rank what topics you're most interested in here. And if your answer is other, please let me know in the chat box so that we can rub those in.
While this poll is going on, is it possible to continue answering questions?
Yeah, you can see the chat box. We can move on with that.
Okay, let's just do that. I think we had a question from Kwong about, I guess it's about discontinuation of isolation criteria, test-based or clinical-based.
Yeah, it's a very hot topic. Right now, CDC guidance leaves us a choice. And they say you can do either a test-based or a syndrome-based approach to clearance from isolation. I think everyone has a higher level of concern for hospitalized patients who may be getting transferred to a long-term care setting. This is a question that actually I think we're trying to keep our finger on the pulse of with acute care hospitals, what their current policies are. Everyone has been gearing up for a surge, and right now in Hawaii, we are not seeing that surge. So that may actually be a reason to think through, maybe we have an opportunity to do a little bit more of the test-based clearance right now. On the flip side of that, we continue to hear about a lot of shortages, both for swab kits, swabs themselves and viral transport media, as well as in some places PPE, although I think acute care hospitals are pretty well covered right now for PPE to do testing if the patient's inpatient. So I think this is going to be part of a larger discussion together with the acute care facilities to find out how they're approaching clearance for patients. What we have not wanted to do is to set up a situation where patients will get backed up in acute care who really don't require acute level of care anymore because of waiting for clearance from a negative test. So I think ultimately what we've emphasized in our long-term care guidance is that as long-term care facilities, we have to prepare to take patients who may be still under isolation. And that's where the facility then has to make a decision, is that going to be a test-based clearance? So I don't have a completely straightforward answer to that for you today. I think while supplies last, I can understand most people feeling more comfortable with the test-based clearance strategy for long-term care.
Okay. All right, Dan had another question. You want to ask that?
Let's see.
About how many
Thank
different
you.
tests there are. Yeah.
Well, I had two questions. One was about testing asymptomatic workers and patients in these congregated living facilities. That would include prisons as well, I think.
Mm-hmm.
And if you're not going to test asymptomatic patients and you're going to use a kind of an appropriate mitigation strategy that applies anyway, then why test at all? Why not just continue to implement good mitigation strategies?
Yeah, it's a great question. I mean, I do think, and on the one hand, doing good mitigation is absolutely the key, because no test is actually going to prevent the disease unless you're doing something about it. And there's many things you can do something about without a test. That being said, probably the role of testing in those settings is more from evaluating how well that's working, because maybe we don't know what the best mitigation strategy is. Right now, as I see it, I don't, at my current understanding, and we're still trying to gather all the info on what is our true supply here in the state. But my current understanding is we do have some limitations in testing supplies. So I doubt that it's feasible that we test everyone in every congregant setting. And whether selective testing can be done with some kind of more of a sentinel surveillance kind of approach, that would be great, so that we could get a sense of whether we're seeing activity in any of these settings. Right now, we're relying on partnerships, engagement, making sure people know that if they have somebody in a congregate setting with even mildly suspicious symptoms, we consider them a high priority for testing and they should be tested. And we at the health department are able to help facilitate that. So if you are in a congregant setting as a doc or a care provider, you're aware of one of these patients, make sure if they're not getting tested, call us and let us know so that we can help facilitate that. So that's sort of the active surveillance that we're trying to do now based on symptoms. But there are reports of how difficult, and we get it, it's hard to do symptom-based screening in a homeless shelter. There's certain settings in nursing homes where a lot of your patients may not be able to verbalize their symptoms very well. So in that sense, we have to kind of watch for the community epidemiology, and when we see a concern in a particular area, we may need to be more aggressive about testing. But I think we have to be guided first by the general epidemiology in order to come up with a sensible approach to testing in those settings.
But then what do you do with that 25% asymptomatic carriage rate?
Right, and I think that's why once you detect it, you've got to go broad with your implementation strategies. So you do have to be really aggressive with PPE, social distancing, how you handle employee wellness checks and break rooms. I mean, that's a huge thing for staff. We're all paying attention when we're seeing the patients, but where are we taking lunch and how are we interacting with our colleagues?
Okay, I think Nicole has some more questions. Well, she's right in the hot spot in Maui, so I don't blame her. Nicole, do you want to raise your question?
Oh, sorry. I just wanted to confirm that we're comfortable with you using a time-based end to isolation for nursing home patients, either that are exposed to known healthcare workers
Yes.
or after they're positive, if they're after their diagnosis.
Yeah, there are, so either strategy is acceptable. So either a time-based approach, and what we do with the time, it's not strictly time, right? It's a symptom-based approach. So when somebody's had onset of illness and they've now been fever-free for at least 72 hours without use of fever-reducing medications, and are at least 7 days out from their illness onset. For most of these patients, it ends up being longer than that. And then also a general improvement, and I would call that in your nursing home population back to baseline. So you'd want to feel comfortable that person is really back at their baseline. If they do have intermittent chronic cough, that's the real challenge in nursing home settings to that syndrome-based approach. And so you have to be comfortable enough with the patient's baseline to make that judgment. So I think the situations where you'd consider test-based release would be where you don't feel comfortable with that judgment. You don't know the patient well enough to know what their baseline is. Maybe they are on immunosuppressive medications. That would be another reason to consider a test-based approach. Maybe they have upcoming appointments that are going to be in a sensitive setting, like hemodialysis or oncology clinic. Those are some situations where talk to us if you're uncertain, and we can work through an appropriate strategy and serve as a resource. Some of this has to come through your hospital systems or healthcare systems and medical directors as well, but that we would like to be able to serve as a resource to handle some of those more difficult decisions.
Thanks, Sarah.
Great. Yeah. I see there's a question we missed a little earlier. Sonia Winslet, you had a question? Are you still there? Anyway, it was something about reports of false negative, then repeat negative, but then the third test positive. Repeat test done by a provider who is highly suspicious may have to do with timing, like viral shedding. Do you want to comment on that?
Yes, I'd appreciate it. Thanks.
Yeah, there are theories about, there have been some papers out of Asia suggesting that maybe further into the course of illness, you may see flip-flopping of a test, for instance. None of us know what that means right now. The science isn't there to say if you have a negative PCR and then a positive PCR, say 13 or 14 days into illness, does that mean they're still infectious? We don't know because the PCR is detecting parts of the virus, but it doesn't tell us if that virus is alive and could infect another person. So we're all very anxiously awaiting viral culture studies, studies on serology that would give us a better, I think in the pipeline, I'm very hopeful in the coming weeks to month, we would have other testing options that would be better answer these questions. PCR is great for certain things and it's super sensitive, but it doesn't answer that key question of can that person still transmit the virus? And so that's why we're still a little on the dark in what these flip-flopping tests really mean.
Thank you.
Okay. The next question was the DOH. Is the DOH receiving all the de-identified data from Miskovich's community screening to gauge community carriage rate?
So right now, COVID-19 is an urgently reportable disease in the state of Hawaii. So every test that's done is required by law to be reported to the Department of Health, and that's for both positive and negative results.
Okay. And Jerome had a question. If one resident is positive, should all residents in the entire facility be tested?
So Katie, can you talk a little bit about our initial mitigation recommendations when there's a positive resident identified in facility?
Sure. So if one resident tests positive, we would certainly do an aggressive response, even to one resident testing positive. So we would, what we've done, oh, sorry, the question just went away. But we've done a little bit of a ring approach, I think, previously, or what we would have considered. We'd look at who would have had the most close contact with the patient or the resident, and who might make sense to test first. Who, it depends on a lot of things, test supplies, things like this. If anyone's symptomatic, we would certainly prioritize that patient or resident for testing. I don't think we can make a blanket recommendation that all residents in the entire facility be tested immediately. And I do think, going back to what Dr. Campbell was saying, was that if one resident is positive, we're going to start by implementing extremely conservative infection control and infection prevention measures. I've heard of partners on the mainland where they have much more limited testing supplies, and once one resident is positive, anyone else that gets sick, they're just considered to be COVID, and they don't even have resources to test even their symptomatic residents. So I think we need to be prepared for kind of all situations. I think we're going to fall back on our infection control measures. I think we would try and implement testing kind of workflows that make sense based on the resources that we have, how many people may have been exposed, things like this, and take it a little bit on a case-by-case basis, but not saying that all residents should necessarily be tested right away.
Yeah, thank you for that. And I think one of the things we're finding from our early experience with some of the healthcare clusters here in Hawaii is that sometimes the testing actually confuses matters more, because you may get a negative and then that, like I said, that person goes on to develop disease, or alternatively, you may test an asymptomatic person and they're positive, and then you realize you don't have staffing for your facility if you took out all the people who were exposed. At this point, we've managed to not put any positive people back in the workforce until they're past their monitoring period, but I can envision a situation where maybe you really couldn't staff your facility with a number of asymptomatic positives, and could you bring them back while masked? We may come to those decision points. And so I think when we start talking about testing in response to a single case, we also have to think through what is going to be feasible based on the results, and make sure we're testing in a way that's going to guide our next action.
Great. Oh, I see that we have the poll results shared, and so we'll take this into consideration, and looks like we're gonna probably have to do another session on testing down the road. Okay, so actually, John, can you just put up the COVID testing resources Word document just to show everybody? And then in the meantime, one last question about, can you comment on antibody testing and other types of testing going on?
Right now, I understand there is an FDA-approved serology, but it's not available in Hawaii yet. And I know there's other testing, serologic tests in the pipeline. We're all very interested in serologic testing and seeing what we'll be able to learn from that. Not least of which is, can we identify plasma donors for people who do become critically ill with COVID-19, and then serofast donors who could be donors for plasma for those patients. So we're excited to see that possibility come online, but right now there's not enough information to know if a serologic result tells you anything about that person's immunity, whether that, another use people have talked about is, could we serologically test healthcare workers so that serofast people would be the frontline workers? That's an appealing idea, but we have to first, of course, know for sure that those people are truly immune and no longer shedding. And so I think there's still some answers to be learned about the test before they're ready for prime time. But I hope they come quickly.
Okay, great, thank you. So unfortunately, I think that, John, I don't see that it's on the resources yet, but we will download it on the resources. I actually created this COVID tested resources page with a whole bunch of contacts and numbers and Hawaii testing sites on there, and we'll have it posted up later today. I just wanted to highlight that as another resource, but I don't see it on the page right now. And yes, there is this big black box that's been wandering around at the frontier for a bit, and I don't know how to get rid of it. So thanks for your patience. I would assume that John is trying to help with that one. Okay, so I think we are kind of at the end of our session at this time. So let me just see, was there any announcements I want to make? Oh yes, there is an announcement. You know, we've been doing all those PPE sessions the last couple of times this week. And I just wanted to announce hot off the press for today that there is a free online training put out by the UH Manoa School of Nursing. There are educational modules, and we're gonna kind of post that at some point in the resources part of the website as well. So I just heard about that today, so I just want to let you know about that. And one more thing. No, I think that's it. So, just to end off, in order to get a certificate of attendance, go to the webpage, complete the online evaluation, and the link is at the bottom of your email invitation. Your comments are very important to us. And we're going to tune in again on Monday, April 20th at 2 p.m., getting ready for telemedicine, because we need to do that. Thank you so much, everybody.
Thank you, very good.
Thank you so much.
Thanks for the DOH ship coming.
Thank you, Aida, for all the work on this. Thank you.
No, thank you. Appreciate all of your work too.
Thanks, Aida.